harder to get the blood out. When you see a person has hypertension, that's that afterload piece. That's the pressure within the periphery that the heart has to pump against to get blood out. That's what you're talking about, increased afterload. That produces hypertension in your patients. But what it does is make muscle work harder, which the heart is going to work harder, and it's going to compensate for it initially, but later it doesn't. And so it ends up being a bad thing later on. The heart chambers get bigger, so the patient ends up with a cardiomegaly, meaning the heart gets bigger, but it gets bigger on the outside and on the inside, meaning that it actually holds less fluid in there. So the chamber actually can't push as much blood out in the first place. So think about Starling's law. You're going to see a little video on this anyway, but that's what ends up happening over time. You work the muscle too hard. When you do that with skeletal muscle, it's fine, because all it's going to do is get bigger. That's why people are so buff. Okay, but you can't do that to heart muscle. It's going to work okay initially, but the compensatory piece means that it's going to work less efficiently later on. So if I don't control hypertension, I'm going to get a big old floppy heart that doesn't push stuff along. And so the end result is the patient has heart failure. Now the reason I just put heart failure up here, and what you're going to see in your lifetime as a nurse, because it's happening more and more, and they have it in the book, you'll see things about high output versus low output, left versus right, systolic versus diastolic. But the reason you get rid of the C in front of that is because every patient is not congested who has heart failure. But that's what we used to write CHF all the time. So every person that has heart failure is not congested. So that's why in your lifetime you're going to get rid of that whole thing. So you'll see heart failure written pretty much for every patient who ends up with it. So they'll talk about, more than anything, is systolic versus diastolic failure. That's the way doctors describe it now. Okay. The easy way to learn it, though, is right versus left. All right, and you might remember this again. So this is the blue bloater. And left is the pink puffer. And these are just talking about the characteristics you're going to see in the patient. You're trying to figure out what's happening with them. Okay, so you think about what's happening when one side of the heart fails versus the other. Now I will tell you, this one is most common, because remember, the left ventricle has to pump out to the periphery. So if you have hypertension, that's the side that's going to get larger and it's going to end up failing. So left-sided heart failure is more common than right. If you have a patient that's left-sided heart failure, they truly can have only left-sided symptoms. So just know that you can fail just one side of the heart, and the left side can be the one that fails. If you have a person that has right-sided failure, they will always eventually fail the left side. So left will always go right, eventually. Okay? It will never stay that you only have that side of the heart that fails. But these are kind of characteristics of what you see with people. Because remember, the right side of the heart is receiving venous blood that is deoxygenated, so that's why they tend to be blue. You're backing up into the portal system, which is the liver, the spleen. So that's why those things get enlarged. Hepatomegaly, splenomegaly. So that's why the patient is bloated around the middle. So that's why we call them the blue floaters. If you see those symptoms in a patient, those are people usually with the right-sided heart failure. Okay. So that's what they look like. Deoxygenated blood, backing up into the portal system, that's going to cause increasing the size of the liver, increasing the size of the spleen. If you do that, it has to make more space, so that means you get bloated out. Okay, now, of course, if you're failing the liver, guess what? You have plasma proteins that don't act right, albumin and globulin, all that kind of stuff, so patients can end up with ascites. Makes it worse as far as the bloating around the middle. And also think about those patients you've taken care of in your life who have liver failure. When you're turning them over and that kind of stuff, you can leave a handprint in their hand, in their side, and come back 2 hours later, your handprint is still there. So they tend to have a lot of sacral edema. So that's what you see on the right-sided patient. The left-sided person is pink, because remember, that's oxygenated blood. They tend to have more respiratory complaints. That's why they call them the pink puffers. They're working so hard to breathe, but they still remain pink, because remember, they have oxygenated blood on that side. Okay. So they tend to have more respiratory complaints. They tend to have more peripheral edema, ankles and feet, kind of thing going on with this person. But they're working really hard to breathe. Crackles in the lungs. Don't get me wrong, right-sided people have crackles in the lungs. But left-sided particularly, that's what's going on with this person. They are working really hard all the time to breathe. That's the person that's orthotic. You can't lay them down to save their life kind of thing. What are you trying to do, kill me kind of stuff? No, you don't want to do that to me. Leave me alone kind of thing. They want to sit straight up, oxygen on, looking really scared. Which is, you know, you understand that. But I do, when you have this person that's symptomatic that way, remember BNP is something that can tell me beta natriuretic peptide, okay, that's in the right atrium, produced in response to volume. That's going to be positive even before your patient is short of breath. So even before you have a person that's puffing, even before you see peripheral edema in this patient, this number is going to be elevated. And sometimes you can see it 20,000 in a patient. Okay, this number is crazy when a person is in full-blown decompensated heart failure. Okay, so just know you can see numbers all over the place. Usually you're going to see, because the normal range is 0 to 130. So a lot of times you see, if you see that person just starting up in there, you may see a 400, 500. Most of the time we see a person admitted to the emergency room because they're really short of breath, that kind of thing, they're in the thousands. My mom had this one time, she was over 20,000 when she was in the hospital.
That's because they can be differentiated one from the other.
Right. Because this one will tell, if I got a person that's short of breath and I'm trying to figure out whether it's respiratory in nature, because I can have crackles with other things that are respiratory. But usually what gives it away, not only is this test going to help me, but look for edema. Patients who usually have respiratory problems don't usually have edema. Because that's also one of those things when you do your assessment and go, oh, that doesn't fit right. I don't see this, shouldn't be something that's happening to the person. So, but BNP is going to be a test that tells me that. I can see that before the patient is positive. Things your patient might tell you beforehand is that my rings feel a little tighter, my shoes feel tight. You know, like I told y'all, think about going to Chick-fil-A. The next day, you put your shoes on, they feel a little tight because you have sodium. Where sodium goes, water goes. This person is having it for a different reason, but the symptoms and symptomatology you see in the patient is the same. Okay, so heart failure is something that we see a lot. So testing purposes, I need to know this one because you see it a lot. Stable angina happens a lot. I need to look at that because that happens a lot in patients. Okay. So I have this person has heart failure. Essentially, I have to correct the problems. I got to give them things because I already know what symptoms am I going to have usually with this person based on have shortness of breath, fluid overload, those types of things that happen with your patients. So what are going to be my drugs I'm going to use? Diuretics is the mainstay. All right. Do I care what type I use?
Yes.
Which one am I going to use, I think? It's going to be my loop one. So that's going to be what I'm going to see most. So that always tells me I got to do what else? Y'all are telling me, I hear you. That's the person that needs potassium replacement as well. So always make sure you look at your lab value for potassium when you're giving a loop diuretic. And the loop you give most often, of course, is Lasix. But you may give Bumex. You know, that's one of those you can use as well. There's another drug that we sometimes use in addition to loop diuretics called Zeroxolone. And what it is a medication you give 30 minutes before you give your loop diuretic. It dilates the renal arteries so that the patient actually gets better diuresis. So it should be given 30 minutes before you give your loop. Okay, so if I got a person I know having massive edema, which you sometimes see, the person you look at, geez, you don't even know how to still alive kind of stuff. All right, this is a drug you might see given before you actually give the patient. It should be given 30 minutes before. It's going to dilate the renal arteries and the renal tubules so that I actually get better diuresis from the loop diuretic I give to my patient. So I'm also going to give potassium replacement because loop diuretics don't care what they get rid of. They get rid of everything as far as electrolytes goes, but potassium is most sensitive. And anytime you have a cardiac patient, you want their potassium to be about 4. It can go up and down, yes, but 4 is the minimum you want them to be. And most people think, well, that's still, you know, but we keep it down to a science. You go like, yeah, 3.6, but if you got a person that's in the hospital for a cardiac problem, it's better to keep their potassium on the side about 4. Okay. So loop diuretics are going to be a big piece of what I give to the patient. So that's going to be get rid of the fluid that the patient has. But remember, the heart is probably not working efficiently like it's supposed to, so I have to give them things that are going to increase cardiac output by giving me a better squeeze of the heart. So that's going to be those drugs that you see sometimes, because you see patients who have heart failure, like, why do we pick the medications? And it's because you're treating what the underlying problem is. So I needed to use a drug we call positive inotrope, something that makes the heart squeeze better. Okay. So the drug you're going to see a lot for that nowadays is Coreg. Even though when you look at the drugs on there, it says, oh, beta blockers are contraindicated for heart failure. But Coreg is the one we use for that. It has alpha and beta properties, so we give that to patients. You may also see patients get DIG. DIG is kind of losing favor. But it does, we still use it because it's a positive inotrope. It makes the heart squeeze better. That's what inotropes do. They actually make the squeeze and contraction better. So that, therefore, it's going to give you better cardiac output overall. Okay, so that might be a drug you use. What do you have to worry about with DIG?
Toxicity.
Toxicity. What, and Selma said apical pulse, you got to look at that. Okay, what is it? What are those things that you see in a patient who has DIG toxicity? What are they complaining about? Nausea, vomiting, halos. Okay. Now the issue that you have, and one of those things you got to be concerned about, not just for me, but when you go to work, especially those of you that want to work in cardiac when you're done. Okay, that toxicity is something that's going to be more prevalent in somebody who is hypokalemic. So when your potassium is low, that's when the person's going to be more at risk for developing DIG toxicity. And guess what we're doing? Diuresing the patient. So when you got a person in acute heart failure, you got to monitor that. Because if they're hypokalemic, that's the person that can really go into DIG toxicity quickly. So that's, you got to worry about that kind of stuff. Okay? So DIG is something that we give to the patients. We're going to check their apical pulse before we give it to them. All right, less than 60, we hold it. And if you're concerned about whether or not they're DIG toxic, the funny thing about DIG is it can produce, when a patient is toxic, can produce every rhythm there is. Most of them are slow, because remember, it also interferes with nodal conduction, meaning that it's going to interfere with how fast the heart goes. But the thing about it is it produces every arrhythmia known to man you can have when a person's DIG toxic. They're usually slow, but it can do everything. So just so you know, it's one of those kind of things that's kind of crazy that you may see that done. All right. We can also use, you got a person who's really short of breath and they're really bad. We can also use a synthetic form of BNP called Natacor. It's an IV medication you give to patients in acute decompensated heart failure when they're in ICU type of thing. And what it does is what your normal BNP does as far as responding to changes in volume, it does for you. But it's very expensive. So it's not going to be the drug of choice that you give to patients, kind of thing. It's for really bad people, so we use that. But we do have a new drug class that kind of is a variation of this, because the first ones that we made off this as oral agents did not work. It's because they only had a very short half-life, or your GI tract burned them up and they weren't working. But now we have a new one. Probably seen the commercial on TV. The sun will come out tomorrow. That guy's singing that song all the time. Ernesto is a new drug. It's a combination of two drugs, because the other drug that we give in this category that helps with ventricular remodeling, this kind of stuff, is an ACE inhibitor. So it's a combination of this drug form that treats heart failure and an ACE inhibitor. So it's a combination drug. The first new drug category we've had in years. I don't care how much drug companies tell you they do all this research and development, drugs are usually one molecule different. That's all. But this drug class is new. We probably had 10 new drugs in the last 20 years. Seriously. Everybody just thinks we have new stuff, but it's really not. It's just one molecule different from something we had before. And they just charge you a lot more money for it. Kind of thing. Yeah.
I read that the first line of therapy for heart failure is ACE inhibitor.
Yeah,
so
ACE
that's not true?
Yeah, they use, because you got to go, it's the acute phase. ACE inhibitors will be part of their routine stuff. It is part of it, because this drug is actually a combination of an ACE inhibitor and this particular drug. Because ACE inhibitors are going to stop ventricular remodeling. That's the thing you look at for them. Okay, so remember I told you about the heart changes on the inside as well. Gets big on the outside. Gets big on the inside, which makes the chamber hole less. ACE inhibitors stop ventricular remodeling. So that's why they're going to be a drug that we use for that. So they're always going to be part of treatment. But I'm thinking about symptoms now, because I'm thinking about this person can't breathe. I got to do that first. All right, so ACE inhibitors are going to be there, or ACEIs, as they were on your patient's chart. That's how doctors usually write them in your progress notes. But this drug down here is what you're going to see probably. They already have a assistance program for it, for people that can't afford it. That'll put it probably at about $50 a month. And I wish I had bought some Novartis. Novartis, I think, is the company that came out with this. But they're going to make a fortune. I'm just saying. I didn't buy the blue pill people. I was like, why do we need all that? Viagra is like, that company made a fortune. I don't know if all these people have written down this fortune, but they get paid. But this one is showing great promise in patients. That's what, it's exciting stuff as far as managing heart failure patients, because you're looking at how we can keep people out of the hospital. I know y'all go like, whatever, because you don't see them in the hospital all the time. But it's one of those drugs that you bring a person in, if they're already on an ACE inhibitor, you have to stop them for a couple of days, and then you start this drug, and then doctors try to max them out within a few weeks. So if you're on the max dose, they've already seen readmissions for patients decrease. So that's the kind of thing that's long-term, we're looking about what we're doing with patients.
I have a question about the blue bloater and pink puffer. That, I know we learned that in respiratory, so is that just indicative of the physical presentation of the patient with heart failure?
Yeah, usually
so it
if
doesn't
you
have anything to do with the respiratory aspect.
right,
Okay.
right. Because the thing about it is when you see them come in, you're trying to figure, I mean, the thing about it is when you got a patient who's in acute heart failure, it really, when they're talking to them, doctor, they ain't gonna matter whether they're right or left. It's just more that you're gonna see which side or which symptoms the person has kind of tells you what type they have. And then looking at their history. Because if you look at them and you talk to them once, you can have them breathe, because during this time they can't talk. But when they're feeling better, that kind of thing, most of them tell you, yeah, I had hypertension, or they may tell you I had a heart attack, you know, and that's the kind of stuff you're looking at overall. So medication is going to be a big piece with this. Okay, so all the drugs that are there, and they may add a few more, because doctors add other stuff based on the other underlying things that people have. The other thing about these people is that you got to teach them about lifestyle modification. And so we know that their issue is volume. What do we have to really teach them about when they go home? Sodium intake. Because that's, remember, where a sodium goes, volume goes, water goes. So that means it's going to increase vascular volume, going to make this problem worse. So dietary teaching along with medications is going to be the mainstay of what happens with this person. So anything that's processed, canned, all that kind of stuff puts them at risk. That's the thing they need to understand. Like, you got to control all of that, because if I decrease the volume that's there, I'm going to actually do better with the patient. And you also want to tell them what things you need to call me for. Those rings tight, you gained 3 pounds in a day, that's something you need to call me about. Sometimes we'll tell the patient, add an extra diuretic at home. You're trying to keep them out of the hospital, bring them to the doctor's office. That's what you don't want to do, is put them back in the hospital. So my rings are tight, my shoes are tight, I'm gaining weight. Those are things I'm feeling more short of breath. You know, I was able to do stuff yesterday and now I can't. Those are things you want to make sure you call the doctor about. Because that's the kind of thing that will keep you out instead of in. And I really think because of the nature of heart failure, because we have so many patients that have it, not just older people, but young people as well, from other issues that they may have had. This may be one of those things that in your lifetime, kind of thing, if you want to do, especially if you want to do something for yourself, be an entrepreneur, get certifications as a cardiac nurse or a heart failure specialist, and put up your own thing and work with somebody in an insurance company, or say you work for, you know, some of you work in other places now, so maybe you work for the school board and you get a contract with Aetna that says, I'm going to see all your people that have heart failure. And we're gonna talk about how you can manage your heart failure and not end up being in the hospital anymore, and follow those people and do something totally outside of working in a hospital, clinic, that kind of thing, and work for yourself and get reimbursed for it. Those are kind of things to think out of the box because of disease process. You know, that's one of those things you can actually look at for thinking about what I might do different later on. Sometimes this patient may have rhythm problems, like I say, so depending on what's going on, sometimes they have atrial fibrillation, that kind of stuff. So they add medication based on whatever their underlying problem is or other issue that the patient has. But it's one of those things, unfortunately, that there's no cure for. All we're going to do is give you medicines to manage your disease. And it becomes that seesaw thing. How can I improve your quality of life? Not drop your blood pressure so low so you have a syncope, you know, kind of thing. But also, so that you can manage and do okay at home. Those are things you worry about with this particular patient. So in heart failure people, the other thing that you're going to do, besides diet and exercise and medication, and making sure you don't come to the hospital, is that if you're going to make sure they control their blood pressure, so they have blood pressure issues, you want to make sure that's controlled in them as well. But a big thing is to actually prevent recurrence of heart failure, because every time they have an acute episode, it makes the heart weak. And one of the things you worry about when we talk about acute decompensated heart failure, that's how it's written in the chart. You know, the patient comes in, you see him in the emergency room, the doctor may say that. They say the patient has acute decompensated heart failure. What they're saying is this person comes in and they're totally full, crackles everywhere, short of breath, that kind of thing. So we do all the same meds we talked about before with the patient, but one of the acute complications that can happen with this is acute pulmonary edema.